mindful eating. We should be concentrating our food while eating.
No, I did this theory one time. We would have board meetings. You remember this, Aunt Kit? We would have board meetings, and I would
Yeah.
play a Coca-Cola being poured, right? And I would just play it over in one square, Coca. And before the
Yeah.
meeting was over, everybody goes, "I gotta go get something to drink." So we program people to think this. The other thing we do wrong is Happy Meals. Do you know what they are in your country? Happy Meals. You know, the kids
Yeah,
get
Happy Meals. Yeah, it's
so
there
the
in India.
toy
McDonald's
and right. So my son would always, we would go to McDonald's when we traveled a lot, right? But he didn't want the junk. He thought French fries and hamburgers were bad. He wanted the salad. So I would ask them, would you give him the Happy Meal if I buy a salad, the toy? Would you give him the toy if I buy the salad? Oh, no, you have to buy the hamburger and but my kid doesn't want the hamburger and the French fries. He wants the salad because he's afraid of a heart attack. And, you know, at a young age, he was afraid of a heart attack. And so they would go, no. So I would have to buy the Happy Meal. So he would get the toy. And then I would buy a salad for him. And I would.
But you know that Happy Meal is, that Happy Meal that is the most unhappy meal you can see.
Thank you. Why didn't they put a salad in there for kids? Why didn't they put a salad in there or apples?
Sorry.
So I agree. It's unhappy.
That's marketing gimmick. I mean, they purposely don't want salad in Happy Meals, and they want people or kids to buy Happy Meal, and they should buy again and again, and then they get obese. And after obese, I think they get a lot of chronic disease. So I would like to welcome Dr. Khullar as well, and on a discussion about obesity. Welcome, Dr. Khullar. Good evening and namaste. So we have
Namaste.
Dr. Sadhu with us.
Unhappy
Dr.
meal.
Sadhu is a pediatric surgeon at Apollo Hospital, Delhi. And we were discussing about obesity, especially in child obesity, because obesity turns out to be a lot of chronic disease. I mean, you are a better judge than us, so you can elaborate how obesity creates a lot of new disease in the lifeline.
Well, you see, as a nephrologist, I would like to limit myself predominantly to what obesity can do to the kidneys. Well, there is a direct correlation of obesity with many kind of glomerular diseases like focal and segmental glomerulosclerosis, and it's actually been seen that obesity could be an independent risk factor for the causation of chronic kidney disease. So obviously, we tend to many a times take the help of Dr. Sadhu to help us take care of the obesity of our patients, because one, it is one of the reasons which can cause chronic kidney disease, and equally important is that we find it difficult to manage these patients once they have advanced chronic kidney disease. I'm saying if we were to transplant these patients, God forbid, if they have end-stage kidney disease, and we were to plan their renal replacement therapy, which is in two forms, either dialysis, lifelong dialysis, or transplantation. Now, we always believe that kidney transplantation is the preferred modality of treatment of such patients, and we would always want to offer. So one big impediment is when we find our patients grossly obese, and when we, from both the recipient point of view, one who is going to accept the new kidney, as well as from the point of view of a donor. So many times we reject a family member who would be willing to be a donor. We would be rejecting them just because they're obese. So obesity is something which scares us as well as nephrologists.
So just to decrease the weight, maybe by bariatric surgery or by dieting or by exercise, the idea is to just decrease the BMI. So by decreasing the BMI, Dr. Khullar agree to me that there is a abrupt change of improvement of the renal function. There is an abrupt improvement in the filtration, and definitely the medicine doses they want to use after the surgery, that will also go down.
Quite interesting, you see, and there was a lot of interest in this field. The jury is still out. I would not be able to say that we have the final word whether we should be advocating bariatric surgery to all those patients who could not manage their obesity through diet or exercise alone, because there are two aspects to it. One is slowing down the rate of progression of chronic kidney disease. If we
Yeah,
subject a patient who already has had a chronic kidney disease, by subjecting them to weight loss surgery, at least theoretically, we can probably slow down the rate of progression of this disease. As I said, we don't have the final answer to that, and we must always keep that in mind, that there are some adverse events associated with such surgeries as well. So we have to very carefully select our patients. Now,
yeah,
secondly,
yeah,
while these patients are progressing from milder form of chronic kidney disease to more advanced, and we know that renal replacement therapy is imminent, we would, as I said, want them to be thinner as compared to grossly obese, because it'll be making our decision to advocate kidney transplantation in them much easier. So there are a whole lot of things which go on in our minds. So with that in mind, there has been a lot of recent research. We have actually tried to see whether it really is the case. When I say that by subjecting them to weight loss surgery, we can slow down the rate of progression, but we need to have a definite answer. That's one. People have seen that diabetes, which we have very often discussed, is the main cause of chronic kidney disease, gets under control in a much better fashion once these patients shed weight, either through the normal maneuvers or through, in the extreme cases, weight loss surgery. So diabetes control definitely becomes better. What we really want to know is whether this translates into slowing down the rate of progression of chronic kidney disease. That's another thing which we want to know. And as I said, the caution is that there are some side effects of this surgery. We have come across cases whereby they had risk of oxalate stones. There was hyperoxaluria. So there were
yeah,
some issues with the weight loss surgery techniques as well. One of them causes a few kind of symptoms, a few kind of side effects, while the other one may not be causing those many. So Dr. Sagu is the master there. So, but this is what goes on typically in the mind of a nephrologist when we are going to subject our patients to weight loss surgery, and when we hand them over to surgeons like Dr. Sagu.
yeah, Dr. Khullar, I agree. I 100% agree with you. So, what is important is the choice of the procedure, right? If the patient is going for the renal transplant surgery, and when we are going for the gastric bypass, I think we should be more conservative by choosing a procedure for that. If we do more restrictive or less maladaptive procedure on those patients, then the chances of hyperoxaluria would be less, and we can have a more chances of improvement of the kidney functions, as well as we can have a check on the progression of the kidney disease.
Quite true. Quite true.
Yeah, yeah.
And Dr. Khullar, our viewers would like to know that if a patient is obese and is having some chronic kidney disease, if the patient, can he sustain the two major surgeries, bariatric surgery as well as the transplant surgery within a span of a year or two?
Well, that's quite an important question, and again, we have to take that final decision on a case-to-case basis. Um, the safety of the patient first, and I'll give you some very interesting observation again at the same time. While on one hand, I'm strongly saying that transplantation is the definitive answer for end-stage kidney disease. We would want to offer that as the definitive treatment for our patients. At the same time, you would agree that majority of these patients have to, unfortunately, since they have no other option, to stay back on dialysis. Now, the interesting observation, what I was referring to was, it has been seen that people who are obese tend to do better. They fare better while on dialysis. So their obesity here is actually protecting them. So when you compare the obese patients with the thinner ones, the lean ones, it was observed that people who were on the obese side had better long-term outcomes. So it's a bit confusing, but then what we have to understand is, given a choice, one would want to subject him to kidney transplantation, and if they have to stay on hemodialysis or any form of dialysis, we would prefer them to be staying in the average range, a little on the obese side rather than on this side of the curve.
I
So,
that is such
Ankit,
an
yeah.
effective statement. I would like to know, for all of the surgeries that you do for people with obesity, how many of them really stay healthy after? Are they mindful, and what is the ratio of people who just go back to the way they were?
Yeah, Ankit, I would like to answer your question first.
Thank
Yeah.
you.
When we talk about the bariatric surgery and when we take a decision of the procedure or we start the pre-operative preparation of the patient, it's a multidisciplinary procedure. And Dr. Khullar and all, and the psychiatrist and everybody, cardiologist, everybody will have a consultation with the patient. Even the my dietitian is also take consultation with the patients. And what important in bariatric surgery is your pre-operative optimization. So doesn't matter whether it is the kidney disease, the diabetes or hypertension, we have to optimize the patient, and each and every consultant sees the patient and optimize the patient. If the patient is not having a controlled diabetes, then the patient's diabetes has to be controlled. If the patient's creatinine is on the very higher side, then definitely the dialysis will help us to bring the creatinine level low, so that we can have a smooth outcome of the procedure. So always the optimization of the patient is very important, and the outcome of the procedure depends on how much you have optimized the patient. So in each and every field, if the patient is diabetic, then we have to control the diabetes, we have to control the blood sugar level, we have to control the serum creatinine level, and other things also. So if we work as a team, then definitely the outcome of that procedure goes very well. So now the answer to the Kim's question. So it is not like that we have done the bariatric surgeries and everything is over. I think the surgeries part is only 30 to 40%. Rest of the part depends on the follow-up of the patient with each and every discipline, not with the bariatric surgeon, with the nephrologist, with the diabetologist, with the endocrinologist, with the nutritionist. If the patient follows up well and patients follow all the guidelines which has been given to the patient while discharging, whether it is a physical activity, is a dieting or control of any other things, if the patient follows well and patient is regular in the follow-up, then the patient's outcome is good. Then only we can have a good result for the bariatric surgery.
Okay. No, I mean, to me, it sounds like a team, like you said, a mental state of mind as well as a physical.
Yeah, everything.
Can I ask, after they have this surgery, how eager are they to get into exercising? And we hear that they feel better after dialysis. And of course you're going to feel better when you start getting your blood cleaned out. I feel better when I clean my body out, right? When I cleanse my body. But how eager are they? Is there a scale model of exercising?
Yeah, we advised basically, I mean, three type of the exercise to the patient. It's a low intensity, it's a aerobic exercises, then body strengthening exercises, and then heavy exercises.
Mm-hmm.
So the normal walking, actually, this is a laparoscopic procedure, minimal access procedure. So the patient starts walking the same day in the evening, and the walking patient can start. But the low intensity exercises, we ask the patient to start after 3 weeks or 4 weeks, and the strengthening exercises we only ask the patient to do after around 3 months. So slowly the physical activity is increasing, and even the diet is also increasing. So it's a post-operative slow process which can help you out for the outcome of the procedure.
No, I think it's lovely.
We would welcome Dr. Moskowitz on our show and on our panel discussion with Dr. Khullar and Dr. Sadhu is with us. So, Dr. Moskowitz, you have shared an email with me discussing about a patient. Can you elaborate what happened with the patient?
Right. So this week, I have follow up on my presumed COVID-19 patient. Um, he's a long-term asthmatic, 18 years old. Had to be on prednisone for 2 years when he was 10 years old. So very severe asthmatic, tough to wean. Developed diarrhea and chest pain a month ago, which is unusual for asthma. He'd never gotten it before, but it's characteristic for COVID-19. And he had it for 2 weeks until the 10th of April, when I started him on 60 milligrams of prednisone, which is typical pulse for an asthmatic patient, which I thought would help his COVID-19. He actually got worse, went up to 100, doubled to 120 milligrams of prednisone within 6 days by the 16th. And finally felt better 2 days later on Saturday, a week ago on the 18th. But then his prednisone dose got divided in 3. So he took 40 milligrams 3 times a day, and he started feeling worse the very next day, Sunday. And by Monday night, he was gasping for breath with burning every time he took a breath, and went to the ER where he should have been intubated. Amazingly, he was sent away, presumably because he had no fever, and got a pulse oximetry test at the fire department, which showed that he was breathing well. He was 100% oxygen saturation, but his pressure was high for an 18-year-old, 150 over 96. So there is some objective evidence that he was in extremis. He never felt that bad in his life and thought he was going to die. After 2 doses, though, of quercetin, a gram each, he started feeling better for the first time in a month. And now, this is now 5 days later, he's on 10 milligrams of prednisone going off tomorrow, and feels better than he has in a month. He's back to baseline. So
Wow.
to me, it's and no one person in the family. There were 7 other people under the same roof. Assuming he has COVID-19, we'll find out tomorrow or rather Monday from a test. His mother took quercetin as well and had no symptoms. But none of the other 6 people in the house have got symptoms either, which is kind of typical for COVID-19. 80% of people have the disease without any symptoms, have the virus without any symptoms at all, which is the problem with asymptomatic carriage and transmission.
It's scary. It's scary. So you've got somewhat of a positive situation going on here in treating somebody like this, because I'm sharing information with someone else who is trying to recover with COVID, with just basic common treatments right now. And he expresses the pain and tightening in the chest, the breathing. Is there something, because that becomes scary? I know, because of the problems that I have. And when you can't breathe, that becomes fearful. When it's painful, it becomes even scarier. Is there something we can give them? I know the prednisone is helping the inflammation. I understand some of the other things, maybe some antibiotics to help clear it out, but maybe something for the pain as well.
Well, I wouldn't give him anything. I wouldn't give him anything other than quercetin.
Okay.
I mean, that's the only thing he needs. In fact, I think that's the only thing the world needs. So my impression is that quercetin is going to prevent symptoms as well as treat them. And I think
it ahead of time. So if you feel like you've been in contact, go ahead and take it as a preventative as opposed to a reactive.
Right. Well, both ways. Quercetin is in everything. I mean, there are many fruits and vegetables with quercetin. Capers have the highest amount.
Yeah, and I don't like capers. Darn it, I do not like capers. I wish I did.
There's also a lot of quercetin in ginkgo biloba.
Ginkgo.
There are
Okay.
tons of ways of getting your quercetin. Apples, dark berries, onions have tons of it, but nothing has more than capers. So, and it's a major component of curry, which is, Dr. Khullar, I think, to follow up on your comment last week that Indians didn't seem to have die as much from COVID-19.
The curry.
I think it's the curry.
Let's make a curry soup. Like chicken soup for the soul. Let's make a curry soup for COVID. There you go.
Yeah. So if I may interrupt here, you see the situation is still the same. We are 7 days later. I would say I still have the same kind of observation. If we look at India as a whole, there are about 25,000 COVID-19 positive cases, and out of which only about 2,500 have died. And only 800 have died, and which is not too many, I would say, still. And if we look at Delhi, from where I am, the capital city of India, we have about 2,500 positive cases, and only about 50 odd have died so far. So what we discussed last time was that maybe there has been under testing, but then at least we are one thing. What we know for sure is that not too many people are dying of COVID-19. So whether it is the curry, whether it is something else, I think is all anecdotal. And Dr. Moskowitz, do you think about this particular patient also, is it going to be anecdotal? Because why I say so is the whole world is still struggling to find out the answer to COVID-19. We had a lot of optimism as far as hydroxychloroquine. The reports in this week especially have said that hydroxychloroquine probably does not have much of a role. Is true about azithromycin as well. Remdesivir, as you had predicted last week, is virtually out of race now. So as I said, the whole world is still struggling about COVID-19. So all these add on to anecdotal things. But what I really liked about was when you hypothesized that maybe it's something to do with the mast cell. Well, we know for sure that there is something different happening when we are comparing people from my country to other parts of the world. There may be some peculiarities. So we may still have to figure them out, but I think I'm quite convinced that there is a difference the way virus has behaved. Now, another thing which probably I hope you agree there with me when I want to bring in the possibility of ACE2 polymorphism. So the ACE2 receptors, which what actually help the entry of the virus into the body, they are different, I think, across the subset of populations. So maybe something to do with what you suggested, the way the mast cells react in our patients. That's one, of course, that's a very valid theory. I think needs to be studied further. And what we are hearing more and more often in the last few days, that maybe the ACE2 angiotensin converting enzyme 2 has polymorphism, which probably could be another reason. But yes, again, fingers crossed. Every week, I would say that yes, the next week is going to be very crucial because we are treading the path very cautiously. But so far, the virus has been relatively kind to our people.
Right. Well, from your numbers, basically 10 times fewer people in Delhi are dying than you'd expect. And that's a pretty impressive thing in biology, a factor of 10, and certainly supports what I'm seeing in my patient. Prednisone actually did well for most of my patients, but this asthmatic guy, and asthma is how everybody dies from COVID. This asthmatic guy with his chest burning and his tightness, I really thought was going to die Monday night, and so did his family. So for him to be completely normal 3-4 days later and start feeling better the very next day after only 2 doses of quercetin is is miraculous. It's certainly remarkable clinically, and I would base my entire reputation on that being valuable for all immunocompetent patients. And given that people are dying every day, I would probably, I would already have suggested that everybody coming out of their house start taking quercetin 0.5 gram a day if they want to avoid dying of this virus. I mean, it'll turn out that there are a million reasons why 80% of people don't have symptoms and only 5% of people die, or 0.5% of people die if you're lucky enough to live in Delhi. And they'll include things like ACE2 polymorphisms and ACE1 polymorphisms and mast cell polymorphisms, Fc epsilon receptor 1 polymorphisms, MRGPRX2 polymorphisms, which is the receptor for the viral nucleocapsid protein. So all of these proteins can be more or less active. And but the one thing we need to know, we already know, which is that even the sickest patient, when given quercetin, gets well within 2 doses. So I don't see there to be any reason why even a single person more should die from COVID-19. There are 2 reasons for that. Number one, my case report, which will eventually get published, needs to be replicated. Number 2, nobody else has anything else to offer. And what the treatment is so simple and so safe and makes so much sense that that I can't see pursuing a million other directions, which is currently what the world scientific community is doing, makes any moral sense whatsoever.
I mean, it's not costing us anything more to utilize this as an application to our everyday life anyway. Just add curry soup to your meal plan. But of course, quercetin, I want to learn more about it. I love this conversation because this is a healthy alternative. This is just something to add to our diet to build our immune system. I'm glad that you had a positive result. Oh my gosh. Like you said, there's so many deaths. We just looked at the numbers. Have you guys looked at the numbers today?
No.
So as of yesterday afternoon, we'll just share with you just so that we could talk about why this conversation is so very important, where you're talking about we don't need to have any more deaths if we're having positive results with something. Here we go. Let's scroll up just a little bit, because this was kind of hit me in the head pretty hard. We're now looking close to 3 million cases in the world, close to 200,000 deaths, probably more. We're finding out that we actually had a lot of cases supposedly in January and February that they weren't properly testing or identifying back then. So, and I keep getting more and more stories every day. But if you look at it, the majority of it, close to 1 million of all of that is in the U.S. So we're definitely showing that whatever it has been that we've been doing was not the proper way to do it. And looking at all of these very expensive drugs that they were touting, I think almost anything that's an anti-inflammatory, something that might have some sort of steroid in it, some anti-fever. I think anything would be helpful, right? Because you're just helping the body have a little bit of ease and help it rest. And we all know, based on all of you doctors, including Dr. Segu, sleep. Get plenty of sleep every day, because that helps you build your immunity system. And he was even talking about how our sleep is impacted if we're not healthy. But this is good news. It's an easy solution to try. Why at this point I say why not? I mean, if it were something that cost us a lot of money and we could be allergic to it and could hurt our bodies, I would say let's think about this. But my thing is why not? Just add it to your diet. Let's get some recipes, Ankit. What do you think? I mean, because look at the data. This data is not good. This this data is not good. We're closing in on some very unhealthy statistics. I think people are seeing some results of not having a big enough control. Willie, how is it down under right now? How are you doing?
We're good. We're good. We've had a slight reduction in the number of the total deaths is. Give me a sec. Total deaths is just 80 at this point in time.
Wow. So looking at comparisons, I would have to tell the people here in the U.S. We're doing something wrong. We definitely need to get a better handle on this, and having letters from doctors from the U.S. They need us to stay home, but nobody wants to. But look at that. That's pathetic.
Yeah. And the overall figures are kind of leveling out. The flat line. So, yeah, just the big pocket of infection, like red spots, or if you want to call it, is Sydney, because Sydney is also quite congested, very similar to like a New York scenario, where people are kind of living on top of each other.
And not eating curry.
Not eating curry.
Not eating enough curry.
Because the sad thing with Sydney is if you walk on a Sydney street in CBD, Central Business District in Sydney, if you take a walk or stroll down the street, for every 20 person you go past, 16 of them would be from China.
Wow.
They're just disproportionate. Like
that's not the case in India.
Yeah. No, I'm not saying this.
It might be in America, or maybe in Australia, or maybe somewhere, but it's not the case in India. We have so many Indians around the world, apart from India, so I think we are good to go.
Well, there are not that many green vegetables in the Chinese diet.
I'm not sure about Chinese diet, but I know that we use a lot of vegetables and we use a lot of spices and oils and a lot of things in our
I think it's spices. I think a spicy life is a good life. And I heard the word apple from one of you. So apples are my favorite.
Right. So, not a big deal in China, though. Fruits and vegetables are not really...
No. There's a Chinese meal they call yamcha. Yamcha, like in the mornings, they're going to do yamcha kind of thing. I have not been to one, so I cannot verify what it is. So, but, I go past and I just look at the photos on the shop front, and there's nothing green there. It's all like
it's kind of a tea. Tea flavors with different. It's like different flavors of mojito in the form of a tea, and a lot of other fruits mixing with the tea. So a lot of Chinese are following those yum chai kind of recipes.
Yeah.
So I would like to ask Dr.
Blueberry.
Transplants going around during this COVID-19 as well. So, what kind of precautions you are following? While undergoing these transplants at your hospital?
Well, you see, the transplant activity was at a standstill, and this was in accordance with the government guidelines. That the advisory was to halt the transplant activity till the time we have more clarity on the issue. So we haven't been doing any transplants of late, I would say, for the last about 3 weeks, barring an exception whereby we just did one about a couple of days ago, whereby a family was really committed and wanted to donate the organs of their relative who was declared brain dead. And that is what actually the enthusiasm of the family, that is what encouraged us to seek a special permission from the governmental agency, and then we went ahead. So the liver was accepted, 2 kidneys were accepted, and I think that was it. but at least so far it's just been about 3 days. The outcome has been quite good. But otherwise, there was an advisory which said that till the time we are clearer as to how this virus is going to behave, we should not be doing any transplantations. For this one, as you asked me, we took a lot of precautions, and the precautions, on one hand, we wanted to be 100% sure that the prospective donor did not have COVID-19, and we did the test twice from the endotracheal secretions. And then the recipients, because for every one kidney, we call about 4 or 5 potential recipients. For these 2 kidneys, we had almost like 7, 8 of them, and each one of them was tested for COVID-19 twice over a period of within 24 hours, I would say. And that's actually for their safety as well as the safety of the healthcare providers, because the doctors attending on to them, the staff, the nurses, technicians, everyone would be at risk if they were having an asymptomatic COVID-19 disease. So, but this is, I would believe, only a short-term kind of situation. Ultimately, there are people who are waiting. We have plenty of them who were about to be transplanted within that week when the government called for the lockdown, and they are eagerly awaiting their turn for the transplantation. I'm talking about, as you know, predominantly in our country, it's the living related kind of kidney donation rather than the cadaveric, which is prevalent in most of the other parts of the world. Unfortunately, it's about 90% the family donors and just about 10% coming from the cadaveric donors. So here, the patients are all set to undergo transplantation, but unfortunately, the prevailing circumstances is not giving anyone the kind of confidence which one needs for going ahead with the difficult surgery such as renal transplantation, or for that matter, any transplantation.
And also, as today's show was discussing about the stem cell research and how stem cell can be a part of a kidney treatment, we were expecting Dr. Yu and Dr. Bill to join us, but unfortunately, they are not able to join us. So, what do you think, Dr. Khullar, about stem cell research and how stem cell could change the way kidney, patient survive?
Well, you see, I'll give you some statistics again here, and I'll limit myself again to the Indian statistics. Every year, it is believed that about 200,000 people land up in a stage, what is called as end-stage kidney disease, and now they are going to require either dialysis or transplantation. Now, just about 25,000 people can actually manage dialysis in our country, and just about 8,000 kidney transplantations are performed every year across the country. Now, don't ask me what happens to the remaining almost more than 150,000 people, because cost is a huge issue. The affordability, the availability of the treatment is a big issue. And looking at the big numbers, so we simply want our patients not to reach the stage of end-stage renal disease, and we could hopefully do something before that. I mean, what we are typically referring to is repair of the kidneys. And now, with that in mind, the stem cell therapy always has had a lot of optimism. But unfortunately, so far, we don't have a definite or a concrete evidence that this helps, as at least as of today in 2020. We are very eagerly looking forward to something positive coming out of it, even though the research so far has been a little disappointing. But in everyone's heart, we are strongly believing that in times to come, we will have something good coming out of it. And I would certainly, I was actually looking forward to hearing from experts like Dr. Yu and Dr. Bill. And in their absence, if I may ask Dr. David Moskowitz, what is his take on something which is theoretically highly promising? I mean, for the sake of the viewers, we are talking about a stem cell therapy whereby you are making some pluripotent cells grow in a particular direction, and you can have new cells which actually can repair the kidney. And there are a few definitions, and again, at the same time, I would like to before I hand it over to Dr. David, some controversies because earlier on, oh, Dr. Bill, so you just at the right time, I was about to try and explain as a non-expert about stem cell therapy, but let me finish before I hand it over to you and Dr. David. See, there was some controversy when we wanted to take these cells from the blastocyst or the embryo. There were some ethical issues. And now the experts like Dr. Bill and Dr. Yu are going one step ahead. They are modifying these somatic cells, one's own cells, which there are plenty of them, and there are no ethical issues involved here. You engineer them, tailor them into the stem cells. So there is going to be no controversy. But whether that translates into something meaningful or not, I think only time is going to tell. So far, it's more of optimism, hope. Over to you, Dr. David, first, and then finally to Dr. Bill.
Well, very quickly, it's a hot potato for me. I'll give it to Dr. Bill right away because I know nothing about stem cells.
Oh, no, don't say that. Everybody knows about stem cells these days.
Everybody knows that they should pay their taxes to the Stem Cell Institute.
So that's why we're having this talk show. We're going to educate the world on stem cells and not to be afraid of it, because if you have the facts, you don't have fear. When you have knowledge of something, and knowledge is very powerful, you don't fear it. And up until now, people either feared it or thought it fake. But let's figure this out and share the knowledge. Good morning, Dr. Bill.
All right, namaskar.
I still think it's fake. So over to
what was the conversation? I heard that some of you guys are experts in dialysis.
Well, Dr. Dinesh is.
I see.
I know enough about dialysis to want to prevent it.
Dr. Khullar, are you in Delhi?
Yeah, I'm from Delhi, and what I was referring to was that for a country like mine, where you have almost like 200,000 people added every year to who land up in end-stage kidney disease, where the treatment options are either dialysis or transplantation, and certainly if the developed countries are finding it quite difficult to cope up with this kind of economic pressure, so you can imagine what is happening to a developing country like mine. So obviously, I would want the kidney disease process to be halted at some stage, so that the disease does not progress towards end-stage renal disease. So we are looking at some kind of repair of the kidney. So I'm not talking about the other organs, limiting myself as a nephrologist to what stem cells could do to the kidneys. So I totally agree with Dr. David here that yes, so far we don't have data which suggests that they are doing miracle. Theoretically, yes, it looks very exciting, and we are wanting to hopefully have something come out of it in a positive manner. So that's why we want to hear to experts like you who could tell us what is going on.
Dr. Khullar, I think a couple of days back, I went over this basic 101 on stem cells. Let's go back on that. I think it'll be very interesting to see where we are going with this whole process. You know, when we have conception, we have a 16 or 22 or 120 cell mass, like a bunch of grapes. I personally believe that at that time there is no soul in those; they're just cells. After division, and on day 4 or 5, I believe that this whole process stops for about 24 hours. Now, what happens during that time? I believe that these cells, 120 cells, are reprogrammed to make the endoderm, ectoderm, and all that 3 layers of the embryo. And they are designated to make, in 9 months, the whole human body. Now, if we believe that that is true, a process that stem cells, 120 stem cells, mother cells, can make a human body, and then when the baby is born, most of these cells are transferred to the baby, and it grows with them. They localize into different tissues as adult stem cells. Not the embryo is left behind now. Now they become adult stem cells. They don't have the same capability as the embryonic cells, but they're pretty good. They still can regenerate the whole tissue based on the microenvironment we provide them. Now, as you notice that as a physician, I'm sure even a layman can understand when we are in our early 20s or our teens, when we fall, we break our leg or break a bone, bruise, we heal very quick. But as we grow old, that process declines and it's very difficult to repair. Sometimes in old age, we hardly repair any bones. Now, what's the difference here? If you look at the whole timeline of aging, earlier on, you have so many adult stem cells being produced. We lose about 300 million cells per minute in our body. But the body, those adult stem cells that have been localized in our tissue, bone marrow and other tissues, we know they're everywhere now. They make about 300 billion progenitor cells. They replace the dying blood cells, they replace the dying tissue cells to regenerate the body. Now, the difference between when we are in our teens versus when we are old is that these cells lose their ability to regenerate due to many factors. Age, they age as well. Toxicity build up in the body. And also, when that process happens, around about in our early 30s, since the process shifts a little bit, more cells being dead than made, or the balance really changes. So what happens is these dead cells keep on accumulating in the body. It's like if you put a rotten strawberry in a bowl of fresh strawberries, it will start killing the rest of them. It will rot the others too. So exactly those dying and dead cells produce certain factors that start killing the cells surrounding them. And they become kind of foam cells. They're half dead, half alive. So that process keeps on adding on to our old age. That's what we get wrinkles and all that chronic conditions. So just imagine that if I come along and say, look, I have a source of stem cells. I can transfuse in your body 300 million cells every 3 months. Tell me if there is any reason to believe why we would not behave like when we were 16. There's no reason to believe. We can be 200-year-old, but our physiology would work the same way. So based on that principle, I believe that every disease can be treated in the body. Every regenerative function can be reinstated if we have the right cells. What's missing here is we do not have good cells in the body when we grow old, and we do not have good cells commercially